And I'm so excited to be here today to have this combined meeting between the Homocystinuria Network America and the Organic Academia Association. We have been meeting with the Organic Academia Association for many, many years. And when the HCU network started the work, we knew that there is so much common ground and that we need to join forces to develop better treatments for the homocystinurias. And we had a big cohort of cobalamin C families that could benefit from joining your network and working together for improving newborn screening for many common goals. So I am very excited to see this happening, and thank you, Margie, for connecting us all together. And it really matters. We, the researchers, really hear from the families, and it is your fundraising, your focused effort to make a researcher really work more on a specific disease. Like we don't come out to decide to work on cobalamin G or cobalamin E or methylmalonic acidemia. Even Dr. Venditti started working on MMA because some families asked him, forced him, encouraged him, supported him throughout all those 20 years that we have been working on MMA to finally reach a stage where we now have 3 or 4 new therapies that you will be hearing here at the meeting. He's talking now next door, and all our cobalamin families are there to hear this development. But there has been a lot of progress that's been made, so we are very excited. This is our group at NIH, Dr. Venditti, Jennifer Sloan, we are here. Susan Ferry is our research nurse, so we have a large group that started studying methylmalonic acidemia and cobalamin disorders in 2002. So we are there for a long time, and we have accumulated a lot of experience with clinical phenotype and seeing the patients over those years, 260-something patients for over 2 decades almost now. And it's important to participate in the research. Now I will skip the pathway because we all heard a lot about pathways and disorders, but I wanted to say here 2 words about the importance of participating in natural history studies, because seeing many people coming from different clinics and doing the same evaluation on every one of them, the same eye exam, the same neurocognitive testing, the MRIs, the cardiology testing, like the same people who are now experts in these diseases, see the different people coming from different parts of the world, really, not just the US. But then we can see what works and what doesn't work. Like everybody's on different doses of betaine, different doses of B12, different diets. But then going through the same evaluations on a protocol help us say, those folks do better, so what do they do different? And then we can change the guidelines and inform the specialists to develop better guidelines for this disorder. So it's incredibly helpful. This is our pathway. Just the 2 words is that B12 is very important for those 2 reactions. One inside the mitochondria that produces energy. Adenosylcobalamin is the active form of cobalamin, and the other one is methylcobalamin that makes methionine from homocysteine. So we need B12 for those 2 reactions. And those early cobalamin defects, the cobalamin C and earlier defects, they affect both reactions, and children have high MMA and high homocysteine and low methionine. While the ones coded in green here, the cobalamin G, E, severe MTHFR, they only cause high homocysteine and low methionine, not high MMA. So this is and then we use hydroxocobalamin to help push those reactions with adenosylcobalamin and methylcobalamin. And cyanocobalamin is contraindicated, and no kid with cobalamin C should be on cyanocobalamin because we need the cobalamin C protein to remove that cyanide, and it can cause problems in the patient. So hydroxocobalamin is the preferred cobalamin to treat all our pathway disorders. And then we use betaine and folinic, and we'll go in more details on the pathway. Again, that's Dr. Chapman mentioned this common effort to develop guidelines, and this is fantastic, but keep in mind that those guidelines are really expert people talking to each other and trying to learn from research that is out there. If the research is not there, it's all a matter of opinion. Of course, collecting opinion from people treating patients for many years matters, but it's not necessarily based on solid research, basic research data. So we need both. But all the guidelines really emphasize to say the quality of the evidence is really low. Like we really don't have good evidence to inform what we're doing. We really need the mouse models, and we really need the basic research to make it better. So, and this is a classic, and those disorders are not easy to treat. And this is a classic example of a cobalamin C young adult who needs to do the injections every day of hydroxocobalamin and is on a lot of medication. He's on 16 grams of betaine. And this is a patient I was talking to the families, is able to make the betaine in capsules and spread throughout the day so that he's able to take that high dose of betaine and every day. Folinic acid, carnitine, he takes a low dose aspirin, and a statin for hyperlipidemia. And Brittany, we can talk about lipids and high lipids in cobalamin C. And here is again trying to kind of categorize the differences between the disorders. They all have high homocysteine, but then we have the isolated CBS, the classic homocystinuria, versus those remethylation defect, the cobalamin disorders, and severe MTHFR. And yes, diet, B6, B12, betaine, folinic is relevant for all of them, but it's very different. Kim emphasized how low diet is very important for CBS deficiency, the classic homocystinuria. We need to lower that methionine. But for cobalamin remethylation defect and MTHFR, we do not need to lower methionine. We need to increase methionine. So we do not restrict protein. That was a big issue for the cobalamin C patients. Then we can use B6 across the diseases. We really need it for the B6 responsive classic homocystinuria. We don't really need much for the cobalamin or the MTHFR. B12 is critical for cobalamin, especially cobalamin C, G, and E. It's not important for CBS or MTHFR. Betaine is used across all these three groups of diseases at different doses. Very helpful for cobalamin and MTHFR. One has to be more concerned for the high methionine in classic homocystinuria, and I have a separate slide on betaine. And folinic acid, again, different doses you see, very important for the MTHFR deficiency, and cobalamin C, not so much for the classic homocystinurias. And again, seeing all these patients in our protocol, just to say here that how much variable the treatments are. Unfortunately, despite the guidelines and despite all the books and textbooks and biochemical guidelines about how to treat the patients, every clinic does it a little different. So people are on different frequency of injections. We were seeing original patients that had injections once every week or a couple times a month, 3 to 5 times a week. Now, of course, most of our patients are on daily injections for cobalamin, for hydroxocobalamin. They were on different doses of betaine. They were on a lot of special medical formulas and other supplements. There is a lot of variation, but again, studying it carefully allowed us to, understand better how things should be done better. And I'll talk about those other supplements first and move to B12 injections last to give you a little more details on that. So betaine, again, 150 to 250 milligram per kilogram per day. I'm talking again for remethylation disorders, not for classic homocystinuria. You see here classic homocystinuria, the doses are lower, around 50 to 100. For MTHFR and cobalamin C, the doses are up to 250 milligram per kilogram per day, even higher than that in some of the cobalamin G and E defects. We have people on 300 or 400 milligram per kilogram per day. It has to be divided in 3 to 4 doses because it's a large amount of the medicine to be absorbed. And we use sarcosin as a marker to see how much betaine is absorbed and utilized. Then folate versus folinic acid. So there is a folate trap, we call in the remethylation defect. So if you use the classic folic acid, it's trapped in the cell, and that causes megaloblastic anemia and complications that are related to remethylation disorders. So the typical folate is not the best folate to use. We have to use folinic acid preferably, which is the active, stable form that is better absorbed in the CNS, in the brain. So folinic is definitely better than standard folate for the remethylation disorders. Sorry, it moved. And then methyl tetrahydrofolate is also used for classic MTHFR. And then if you use classic folate, especially in severe MTHFR, it can decrease the uptake of the folate to the brain, so it has to be avoided in MTHFR deficiency. So there is a better folate or folinic versus typical folic for this type of disorders. Now, pyridoxine is a cofactor for the classic homocystinuria. It has to be used in combination with folinic. Kim talked about that, and it's used in lower dose for the remethylation disorder. Riboflavin is a cofactor for MTHFR, again, another supplement that some MTHFR deficient patients can be on. Now, oral methionine, there was a question earlier. It can be used to give the end product that's missing. We prefer to use the cofactors to push the enzymes in the brain and in all the organs that need to be helped to make more methionine, because then we think this helps the methylation in the brain better than giving an oral syrup of supplement of methionine. We don't want to just improve the plasma level. We want to help the enzyme do its work in all the organs that it needs to work. So we prefer to give more B12 or more betaine and help make more methionine than supplement it from the periphery. But it has been done, and it can help improve the methionine levels. But again, if it has any effect on the eye disease or the brain disease, there is no studies to prove that. And then some people help, so methionine is used to make choline and creatine. So some patients and clinics have supplemented choline or creatine as well. So those are all things that make sense for the pathway, but there are no good studies to support the use of one or the other or what the right dose is for each of those different supplements. Diet has changed a lot for us. We did a lot of work in our group to show that diet is not necessary for cobalamin C deficiency. So we use, as we said, high-dose cobalamin and high-dose betaine to synthesize more methionine. But on the other hand, because those children had elevated MMA that comes from the protein, the clinics were reducing the protein in the diet, and they use special formulas that don't have any methionine in the formula, and had a lot of leucine that blocked that methionine from going in the brain. And that was, it was just the wrong formula to use for those children. And that has now changed a lot. In the recent years, we don't see any younger children on the special formulas. On the other hand, while we say you don't need to restrict protein for the younger children, we don't want to use too much protein as the children grow older, because we need to take care of their heart disease and the cardiovascular system. All our methylation defects have very high homocysteine, and if you have high homocysteine for all your life, that can give you cardiac complications in combination with the high lipids. So we need to take care and follow a heart-healthy diet, we call it, like more vegetarian-based, normal amounts of protein, not too low for sure, but also not too high, because we cannot keep increasing the B12 as they grow older. We have a limit to how much B12 we can give every day. So we need to lower the protein as they grow older, after they're teenagers or early 20s. We have seen people on high-dose B12, if they learn to eat more protein, their homocysteine, and it will be quite high. So heart-healthy diet, long-term. Injectable B12, it is approved to be used intramuscularly. That is the proper way to provide B12. But we have now, the Colorado group has started this, and we have switched many patients from intramuscular to subcutaneous injections, because it makes it easier for the families to move to different locations. And we were able to teach some of our older patients to self-administer the shots. It's kind of an insulin shot. It's like a smaller needle. It can be used and changed in different locations. The patients have low vision, so it's hard for them to do any other shot. But a subcutaneous shot is relatively easier to do, and some of them are able to do it themselves, because parents will not be there forever, and we want to teach them, if they're able to learn, to be able to give the shot themselves. So that was the purpose for it. So, and then you all know it is important to have the shots, and there is different ways and different size of needles. This is the intramuscular injection size of needles, and the subcutaneous. So an insulin syringe is good for a younger person. We need a little tubulin, we call syringes, or 25 gauge 5/8 needle for the adolescent or older children. The Colorado and the group in Belgium have used the Mediports. Those are little subcutaneous ports that the diabetic children use to give insulin shots. They need more injections every day than just one, so they have several insulin shots a day. So that makes more sense for the diabetes population. But some clinics have tried to use subcutaneous catheters or a port, so that you inject and you change that port every 4 or 5 days, so you can use the same site to inject the daily shot. It's not adopted by many families, but it's out there for you to consider with your doctors if that is it's appealing to you. So now the frequency of the shots is changing with time. There were papers earlier that said that it takes weeks for the B12, like if you give one shot, the MMA and the homocysteine is stable for 2 or 3 weeks, that the kids can space out the shots, not do them every day, but do them maybe every 2 weeks. So there was some literature for that. So the clinics had changed that and changed the frequency of the shots to a couple times a month or once every week. But clearly there were more papers then after that showed that 3 times a week of cyanocobalamin, this is a head circumference graph, and normal is here close to the 50th centile for the head growth over the years. If you use cyanocobalamin 3 times a week, there is no effect. The head stops growing, doesn't grow at all. If you go to hydroxocobalamin 3 times a week, the head starts growing, starts going in the normal centiles. But if you use hydroxocobalamin every day, the kid's head growth was near the normal level. So it is clearly shown and proven that everyday shots is very important for cobalamin C children for their brain growth to work. So I think there is no doubt about the daily frequency shots need. Now, homocysteine, you all know, normal homocysteine is less than 13, really low. I don't know why my dots here in the graph don't show. Something is different here, but this was a graph showing, oops, oh no, I've messed it up. Sorry, I think it's a Mac conversion issue. I was trying to see if I can move that graph out. Yes, perfect. So that shows that with kids on the 0.3 milligram per kilogram per day dosing, which is 1 milligram every day that we give in the infants, if we continue that dose 1 milligram every day as the kids grow older, 10 years, 20 years, the total homocysteine was over 100 for many of our children. So we want the homocysteine to be less than 100 to avoid thrombotic events, if possible even less than 50, but this is almost impossible when they grow older. So we and others started increasing the dose in those older children because the dose of B12 was very low when they were big adult male, big size people. So we started doing that. We increased the dose, and we did it very carefully. We measured the B12 level, the MMA level, the homocysteine level in this young adult who came from 3 times a week to 10 milligrams every day, 20 milligrams every day, and showed that homocysteine could be lower than 120. We could bring it down to around 50 with 20 milligram a day dosing. And the MMA improved and the methionine increased. So we showed that a high dose B12 can be more efficient in controlling the metabolites. And then, as we discussed before, we changed people from intramuscular to subcutaneous injections. So this young boy, you see here, this is the B12 that we measured in the serum. And he went from 1 milligram 3 times a week to 25, 3 to 4 times a week to 25 milligrams daily. And you see his homocysteine went from 120 down to 40, 50, 60. And the serum B12 increased really very much to 1 million picogram per ml. Changing from the IM injection to the subcutaneous injection, it doesn't affect the serum B12 levels. And his homocysteine stayed in the 60 to 70 range. Now about a third of our patients take the injection subcutaneously, and the control of the homocysteine is about the same than on intramuscular. So it can be done, and it helps families deliver it easier. So the B12, most of the children are in this standard dose of 0.3 milligram per kilogram per day, but now we have a number of children that take more than 2.2 up to 4 milligram per kilogram per day, 25 to 30 milligrams every day. And we can show that this has a biochemical response. Like it will lower the homocysteine and it will lower the MMA, but it was unclear what the clinical result was from that. If you are already older and you have the severe vision loss from cobalamin C or seizures and severe neurological problems, intellectual disability, this will not reverse. It will not get much better. We just want to keep the homocysteine at a safe level long-term to avoid long-term complication, especially from the heart and other systems. But we really don't try to increase all the doses to all the older children because it is expensive for the families. It's hard to purchase. It's compound made from different pharmacies. It's not formulary. Your doctor cannot prescribe it. It ends up to be a very expensive treatment to keep long term if we don't know that it has a clear benefit. What was interesting, though, to note, and something we really need to study much more, is whether if we can go younger, to the younger children, and go with a higher dose, if that would have a clinical benefit. And really, families pushed their doctors and the clinics across the country. It was really the families that pushed for this, to start using higher doses at a younger age. And with time, we started seeing in our protocols families that came on 2 milligrams per kilogram per day, 20 milligrams when the kid was 2 years old, and 1 year old, and 3 year old. And their IQ was much improved compared to our historical cohort. So now this really messed up my slide. Sorry for that. I think this is a Mac issue. All right. So compared to our historic cohort, this is all our children before newborn screening that presented, at different ages. They had a very low IQ, cognitive performance score. And this is another newborn screening cohort from Mount Sinai, again showing a big spread, but really low neurocognitive outcomes. But then the kids that are diagnosed at newborn screening, the kids that are on higher dose B12 and no medical foods, we really have seen children have a much better neurocognitive outcome, which is very encouraging, very exciting. And now this is, I put that this slide to say that this is now experimental. Can we go to ultra high dose in the very young babies? Like, can we use 20 milligrams or 30 milligrams in a newborn and in a very young child? This has been done now for a very small number of children. It was shown earlier that giving high B12 during the pregnancy could result in a much better outcome in the younger child compared to the sibling. So this was a cobalamin C young girl that had a presentation and a standard therapy with not as much B12, diet restriction, had severe vision loss, was unable to walk, no speech, severely like a classic cobalamin C presentation. Her sister, who was treated in utero with 10 milligrams 3 times a week, and then following that, again, high doses after the pregnancy, she had an IQ close to 100, that's normal, and better vision. So that was encouraging. And this group in Belgium did publish 3 symptomatic cobalamin C patients with very severe mutation that they used 20 to 30 milligrams in newborns, in 1 and 2 and 3 month old children. And they were able to normalize the homocysteine. We had never seen this in our cohort. They could never have normal homocysteine with cobalamin C. So that was very encouraging. And they reported that the cognitive outcomes were better and they had very mild visual impairment at 3 to 4 years of age. And because we have seen in our natural history 80 patients with cobalamin C and many with this severe mutation, we know that it's not possible to have normal vision with this mutation at 3 or 4 or 5 years of age. So this was extremely encouraging. So we have now seen and examined 2 patients with this severe mutation that used 5 milligrams a day from very young age and had normal vision. The first case is 7 years old now, and the other one is the young girl is 2 years and 10 months. And we encourage the clinics to publish their cases so that we can collect this information from the sporadic cases across the world that try that. So that we can go to the FDA and help support approving this for this disease if it works for everybody. Because right now it's a difficult situation for us, and many families contact us about what to do and how to increase the B12. And it's really very difficult because it's very hard to access. It's not formulary. Insurances don't pay for this. It has to be prepared in a compounding pharmacy. There are many impurities in those preparations. Some of them can have cyanocobalamin that we know they don't need to not have. And then they have different preservatives because some states require things to be frozen and without preservatives, and some others don't. So there is a mixture of pharmacies and compounding that is happening that's not ideal. We have not seen severe side effects in older patients that have been more than 80 patient years, meaning one patient has been on 7 years on the high dose. So if we combine all the years and patients that had high dose, we haven't seen any safety concerns, but we don't know what the safety is for the young infants. So we really strongly think that we need a study to collect information in a systematic way for high dose treatment in the very young babies, so that we can establish the safety and the efficacy. And another note is for peripheral neuropathy and seizures can happen with high dose B12. So we tell people to always be on the lookout for seizures. And with this disease, our treatments don't completely prevent all the long-term complications. And for some, because now we hear from people from China in different countries, we have heard young children on high doses that have increased liver enzymes. And we are concerned of this becoming kind of a widespread practice without proper evidence that it's safe and efficacious. So we clearly know that detecting newborn screening and diagnosing the children early will have a better outcome for the cobalamin C and all the remethylation defects. So we fully support the efforts by HCU Network America for better newborn screening. I think it's one of the disorders that we clearly have a treatment that will change the outcomes. We need to unify our treatment approaches, have guidelines, and have better treatments that all the clinics can follow. And then for us researchers to do the basic research and have clinical trials that we study this early and high dose B12 and see what effects we can achieve with the eyes and the neurocognitive outcomes, so that we can have FDA approval and have it available for all the families, not only the ones that have a compounding pharmacy or can afford it or all these different things. So we need all of you and all the voices here to work together and go to the FDA and go to the pharmaceuticals and try to make this work for the families if it's a common goal. There's a list of resources for HCU that we share with families when they come to the NIH. This was a meeting that we had last year with many talks about cobalamin and the remethylation disorders. Thank everyone and the Family Foundation for this fantastic work and for bringing us together. We're all in this. It takes a village. This is my email and for contact for any questions. So I know Jen has a lot of mouse slides, so I want to give her the floor. But yes, absolutely.
Yeah, just one question.
Yeah. Yeah.
So is 30 milligrams in max?
Yes. For now, for us in the US, in most of compounding pharmacy, 30 milligrams in an aqueous solution is the maximum concentration that the pharmacists can compound. The group in Belgium was able to concentrate to 50 milligram an ml. So they used some different solvent or so that was able to go in solution, because after that it precipitates. It's not a solution anymore. So you need to process it somehow to make it higher concentration and still be able to inject it. So again, pharmaceuticals have to work on making it more concentrated, be able to give it and maybe try to find a form that we don't need to inject every day. There are things that we can do to help the delivery of this. But exactly, one more than one shot is hard. Now, if you have this port, maybe you could inject in the morning and in the evening, but to have multiple injections a day without knowing if any of this will affect things, we don't recommend it. I think as long as the homocysteine is less than 100 and we avoid thrombotic complications or side effects, we don't push for more B12 or more. We can talk more.